a 22-year-old male with a history of asthma presents with acute-onset retrosternal chest pain and neck swelling following a severe coughing fit. I am showing you his frontal chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates fine, lucent streaks of gas outlining the left and right borders of the heart, the ascending aorta, and the trachea. This gas extends superiorly into the soft tissues of the lower neck, representing subcutaneous emphysema. There's also a thin, lucent line beneath the heart connecting both hemidiaphragms, consistent with the continuous diaphragm sign. The axial computed tomography scan confirms pockets of free gas tracking throughout the anterior and middle mediastinal compartments, surrounding the trachea, great vessels, and esophagus. There is no pleural effusion or pneumothorax. These findings indicate a pneumomediastinum with associated deep cervical emphysema.
What is the most common pathophysiology behind this condition? And how does pneumomediastinum behave on a lateral decubitus radiograph compared to a pneumothorax?
The most common mechanism is alveolar rupture due to elevated intraalveolar pressure, known as the Macklin effect. Air dissects centripetally along the bronchovascular sheaths to the hilum and then into the mediastinum. On a lateral decubitus radiograph, pneumomediastinum does not shift in position or change configuration because the gas is trapped within the mediastinal fascial planes. In contrast, a pneumothorax will shift freely to the highest, non-dependent pleural space.
What are the two most critical life-threatening causes of pneumomediastinum that must be excluded in a trauma or acutely ill patient? And what diagnostic investigations are indicated?
The two most critical life-threatening causes are esophageal rupture, such as Boerhaave syndrome, and tracheobronchial tree rupture. To exclude esophageal rupture, which classically occurs after forceful vomiting, we should perform a water-soluble oral contrast esophagogram or computed tomography chest with oral contrast to look for leak. Barium must be avoided due to the risk of mediastinitis. For suspected tracheobronchial rupture, which typically presents after severe blunt trauma with a persistent air leak despite chest tube placement, a computed tomography chest followed by urgent flexible bronchoscopy is indicated to localize the tear. If spontaneous pneumomediastinum from alveolar rupture is confirmed, management is supportive and conservative. I would coordinate with the clinical team to exclude these emergencies.